over the long course of time, technology has changed what kind of marketplaces we have. So, of course, the telegraph and the telephone made big national markets where before there'd been only very local markets. And then in the 1850s, the undersea cable became something like the Victorian internet. All of a sudden, the cotton market in the United States could be linked to the fashion market in London. And that made a global market that made it start to work much better. And of course, the real internet, the thing that we're talking about today very largely, brought us companies like Taobao and eBay, and banking services and payments. And those are markets that naturally benefit from a global reach. The more people you can talk to, the thicker the market is, the better it works. But smartphones have started to make possible big global companies that focus also on very local markets. So Didi and Uber ride-sharing, you don't want a driver who's on the other side of the world. You need a driver who's very close to where you are. So some markets naturally tend to look inwards, and some tend to look outwards. So let me just tell you about some local and particular markets to sort of show the difference between the ones that naturally look inwards and the ones that naturally look outwards. I've been involved with two markets that tend to be very particular. One are labor markets for doctors in the United States, and the other is for school choice systems in particular cities. And of course, cities try to put children in schools in the same city. Even though the technology is very general, the marketplace is local. And doctors, more puzzlingly perhaps, tend to fractionate into specialties. So the kinds of marketplaces that my colleagues and I have helped design in the United States have become very specialized. Pediatric hematologists participate in a different market than pediatric cardiologists. So here's a market that you could think of, you might have thought it would be a market for doctors in general, but instead particular kinds of doctors participate in different markets. And the closest comparison I can think of in China is college admissions, where of course the Gaokao is a national exam that students prepare for vigorously, but it's organized on a provincial level. And not only do the national universities have quotas on a provincial level and admit people provincially, the provinces have different algorithms by which they aggregate the preferences. That's something I could spend a long time talking about. But instead, what I want to talk to you about today is, these markets are broken up into provincial markets, but there are a lot of markets that can spread beyond national boundaries. And the one I want to talk to you about is kidney disease and transplantation, which is a global problem. It's one of the leading causes of death in every country in the world. But the way we handle it, the best treatment for kidney disease is transplantation. And there's no country in the world that's doing a good job of transplantation. So on the left, I've got incidence per million population of deceased donor transplantation, and on the right, living donor transplantation, because kidneys are special. Healthy people have 2 kidneys and can remain healthy with 1. So if someone you love is dying of kidney disease, you could donate a kidney and save their life. But even the dark brown are the highest incidences, so places like North America and Western Europe. Even in the places where we have the most kidney transplants per million population, we have many, many too few. The need for transplantation far outstrips our ability to find transplantable organs and transplant them into people. So to give you an idea of the magnitude of the problem, in the US this morning, there are 100,000 people on the waiting list for deceased donor kidneys, for a kidney from a dead donor. But we're only able to do about 14,000 of those transplants a year. It's very hard to die in a way that makes your organs acceptable for transplantation. So you can see that the wait is long and dangerous, and people die while waiting. And the same is true in Europe. The waiting list is much bigger than the number of transplants that they manage to have. So this is a problem even where there are the most transplants per million population in the world. And Of course, another way to get transplants is from living donors, but in the US, we only have about 6,500 transplants from living donors each year. So the demand for organs is much, much greater than the supply. And with living donors, one difficulty is sometimes you might be healthy enough to give someone a kidney, but you can't give it to the person you love who needs a kidney because kidneys have to be well matched. And this is where economists come in and organization of digital markets comes in, because this opens the possibility of exchange. And the way exchange works is on the top we have a donor one loves recipient one and would like to give her a kidney, but can't easily because they have incompatible blood types. And what we used to do before kidney exchange is we'd say to donor one, it's too bad, you can't give a kidney to the recipient you love, go home. And the recipient will stay on the waiting list for a deceased organ donor, that long, dangerous wait. But what you see in the picture is that there's another donor and recipient with the same problem, and that together they can solve each other's problems, because recipient 1 needs a blood type B kidney, and recipient 2 needs a blood type A kidney, and those are both available. So by exchanging kidneys between these pairs, we can get 2 transplants that otherwise would not have been possible. So that's the idea, the basic idea of kidney exchange. And it's a special kind of market because in most countries of the world, like the United States, we forbid paying for a kidney. So there's no money changing hands in that picture. There's just a kidney changing hands. And the same is true in Europe. It's true everywhere except, well, with a few exceptions, the most notable being Iran, where there's a monetary market for kidneys. But in Europe as well, you can't buy and sell organs for transplant. So as a result, because you can't write a contract for a kidney, doing even a simple two-way exchange is logistically difficult. So here's a transplant going on in Cincinnati, Ohio in 2006. I'm the man in the yellow gown keeping my hands out of the way. And there's a kidney in the bucket there, and it's going to go into this gentleman. And that's because the donor traveled from a nearby city of Toledo, Ohio, to take part in this exchange. And at the same time, in Toledo, Ohio, a nearby city, the other part of the exchange is going through. And the reason we do it at the same time is to make sure that one pair doesn't give a kidney on day 1, say, and then fail to get one on day 2. So that these happen at the same time, literally the same time. And that means that even this simple exchange requires 4 simultaneous operating rooms to do the 2 nephrectomies, the kidney removals, and the 2 transplants. So even a simple exchange between just 2 pairs is hard to do. So we understood that if we wanted to have a larger scale market for transplants, we'd have to find another way to organize exchanges. And that came about with non-simultaneous exchanges that are begun by a non-directed donor, an altruistic donor. And the way that works, we have a couple of hundred non-directed donors each year in the United States. These are people who are healthy enough to give a kidney and would like to give a kidney to someone, but don't have a particular patient in mind. And so you can start a chain with the non-directed donor who gives to a pair, who then he gives to the patient in a pair, and the donor in that pair passes it on, and the donor in that pair passes it on. And organized in this way, each patient-donor pair gets a kidney before they give one. So if the link is broken, it's disappointing, but the pair hasn't been harmed. They still have a kidney and can exchange and can participate in kidney exchange next week. So when you do an exchange like this, when you organize a chain like this, you can get a lot of transplants done. There are 20 people in this picture, and the lady at the bottom, Helena McKinney, eventually was matched and added another 12 people to the picture. And some chains can be quite long. In 2012, this was the longest chain we'd seen so far. This has 60 people in the picture. Some chains have been longer, but the average chain in the United States has 10 people in the picture. Okay, so each chain accomplishes a lot of transplants. Now, there's some mathematics involved in this. It turns out to be a computationally hard problem to look at a database of the kind I'm going to show you in a minute to find an optimal chain. So these problems are NP complete, and some of the instances are hard, but so far we can solve them, but they take real computation. So why are long chains needed, and why is it going to be that an international market will be a better way to organize kidney transplants? Well, many pairs are hard to match. They don't just have blood type incompatibilities, they can have tissue type incompatibilities that have to do with the immune system. So when a woman gives birth to a child, she may develop antibodies to the proteins that her children have from her husband, and now she can't take her husband's kidney anymore because her immune system would attack it. And someone who's had a lot of blood transplants, blood transfusions, can develop antibodies to the other proteins in the blood. And so you develop antibodies to the proteins that are common in the population around you. And that makes it hard for you to take kidneys from the people around you. And it can be very hard. There's something called the percent reactive antibody. And if you have a 95% reactive antibody, what that means is that 95% of the kidneys that look like you should be able to take them, you won't be able to take. And as you can see from the distribution that we have here, we have a lot of hard-to-match patients in the United States. We also have patients who are hard to match for a different reason, and they don't have a lot of antibodies, but they have blood type O, and there's a shortage of blood type O kidneys. And when you look at those hard-to-match patients, they are very hard to match. They actually are in the 99 to 100% range. That means they can hardly find any kidneys that they can take. So here's a picture of a database, a tiny picture of a database, a picture of a very small database. Every circle represents a patient and a patient-donor pair. And an arrow goes from one pair to another if the kidney can go from the first pair to the second pair. And what you observe, and everybody in this picture, everybody in this database, all the patients and all the donors, all have blood type A. So there's no blood type incompatibilities in this picture. But what you see is, nevertheless, there's only 8 pairs that have a lot of arrows going into them. Those are the easy to match pairs that could take kidneys from a lot of people. Everyone else is a hard to match pair. What does it mean to be a hard to match pair? It means that for the donors around you, you have a 99% PRA. There's only a 1% chance that you can take another person's kidney. So why can't we do simple exchanges? Well, supposing we each represent a patient-donor pair, and we're all 99% PRA, we can only take a kidney with probability 1%, then what's the chance that we're a pair, what's the chance that we can give you a kidney? It's only 1%, it's very small, we probably can't give you a kidney. But in a big room like this, the chance that we can give somebody a kidney is not so small. What's the chance that you can give us a kidney back? It's only 1%, it's very small. But the chance you can give a kidney to someone else is pretty big. And the chance that they can give a kidney to someone else, and they can give a kidney to someone else. So that's how chains form. So when we have a non-directed donor, we can find a chain. And finding the right chain, the best chain, is a computationally hard problem. So in the United States, we've grown kidney exchange to be about 15% of living donor exchange, but it's not enough. We still have 100,000 people on the waiting list. And in Europe, they've started to do kidney exchange, but at a much smaller scale. If you look at the bottom line here, you look at the longest chain they've already conducted, and you see that they're not using chains very well in Europe. So there's room to grow, but when you look at the whole world, what you see is, in the rich countries, there's a lot of deceased and living donation per million population, but there are poorer countries where good hospitals exist. There are transplants, but not many people get them, and it's often due to financial concerns. In the Philippines, for example, the national health insurance doesn't cover transplantation. So it's But nevertheless, millions of people die of kidney disease around the world. So it's possible now to invite people from lower income countries into American Kidney Exchange to participate. And here's the first pair from the Philippines, Jose and Christine. They were an easy to match pair, but in the Philippines they couldn't get transplants because they didn't have private insurance that would cover it, and the national insurance doesn't cover it. So they entered an American chain, and they got a kidney. Jose got a kidney from an American non-directed donor, and Christine, who's blood type O, is able to start a chain that continues in the American Kidney Exchange case. And they're now home on their 4th anniversary with an escrow fund in Ohio paying all their post-surgery medical expenses. And where does that money come from? It turns out that global kidney exchange is self-financing because the medical system in the United States or in any wealthy country is paying for dialysis, and dialysis is much more expensive than transplantation. A transplant costs about as much as 1 year of dialysis, and then you don't have to do dialysis anymore. So from the savings of transplanting an American, you can afford to invite in foreign patients from lower income countries for free. So it's a special kind of mutual aid that works in 2 ways. One is hard-to-match patients can find easier matches far from home because they have antibodies to people near at hand. And the other is that this mutual aid comes from the savings that transplantation provides. So you don't need outside financing for this. And it's starting to get some support. Here's another chain in Mexico where the Mexican pair is in the middle of a chain. Here was an American who was hard to match. She was going to give to someone on the deceased donor list, but giving it to the Mexican lady is able to continue the chain. These things have been well received in the places where we do them. Here's a Newsweek in Spanish whose cover story says, transplants of kidneys between the US and Mexico, a bridge of life. And it goes on to say, Donald Trump is building a wall between Mexico and the United States, but surgeons are building a bridge. Now, of course, to be able to do this, you have to have the medical facilities in poorer countries where they don't necessarily have the finances, and that's largely true. I'm sitting here in Ahmedabad in the state of Gujarat just last month, where I went to try to help organize kidney exchange there, and it looks very possible. The surgeon is sitting to my left. I'm the man in the foreground here, and he's looking into binoculars, and what he's seeing is a highly magnified 3-dimensional image, and he's controlling from where he sits the instruments that are inside the patient. So the technology, the medical technology, the surgical technology exists to do these things. What's needed is the organization, the database, the computation, the international cooperation. So kidney disease is a global problem. Wherever you're doing kidney transplantation, there are hard-to-match patients who would be easier to match with foreign donors than they are with local donors. The medical technology is much more widely available than the organizational technology to organize chains. And so the digital marketplace of the data of who can match to whom, what are everyone's blood types and tissue types, is something that can help organize kidney exchange around the world in a way that will be globally inclusive and will include lots of places that now don't have access to this kind of medicine. Thank you.